Okay, my friends, let's talk about menstrual cycle. So questions that confuse you on your big exams, board exams. Actually, this might be interesting not only for students, I suppose. So about menstrual cycle. So take your pens, papers, and let's go. So the questions like this will be on your big board exam. So let's start. And first, of course, we have to talk about hypothalamic pituitary ovarian HPO axis. So HPO is a hypothalamic pituitary ovarian axis. Of course, it's a sophisticated feedback loop. The entire cycle is orchestrated by a complex feedback system involving the hypothalamus releasing gonadotropin releasing hormone, GnRH. GnRH is a gonadotropin releasing hormone, the anterior pituitary gland releasing follicle stimulating hormone, FSH, and luteinizing hormone, LH. And the ovaries producing estrogen and progesterone. This isn't just a simple cascade. It involves both negative and positive feedback loops. So the might cycle from negative to positive estrogen feedback on LH secretion is a remarkable physiological event triggering ovulation, my beloveds. So means early in the follicular phase, my beloveds, lower levels exert negative feedback on FSH and LH. As follicles grow and estrogen rises, it suppresses FSH, follicle stimulate hormone, negative feedback, ensuring usually only one dominant follicle develops. But then, once a high threshold is sustained, it paradoxically triggers a massive luteinizing hormone surge, so-called positive feedback. After ovulation, progesterone and estrogen from the corpus luteum exerts strong negative feedback on both gonadotropin-releasing hormone and gonadotropins, so-called follicle-stimulating luteinizing hormone ratio, FSH-LH, preventing new follicle development. What is clinical importance of that? So understanding this axis is fundamental. Why is it so fundamental, my beloveds? To diagnose menstrual disorders. So diagnosing menstrual disorders. So conditions like polycystic ovary syndrome, PCOS, polycystic ovary syndrome, often involves this axis, HPO axis, dysfunction. Hypothalamic amenorrhea results from suppressed gonadotropin release due to stress, excessive exercise, low body weight. Hypothalamic amenorrhea results from suppressed GnRH release. I repeat, stress, excessive exercise, low body weight. You will be asked about that, my beloveds. Then, infertility treatment, my beloveds. Some medications manipulate this axis. So we know that, for example, clomiphene citrate alters estrogen feedback. GnRH agonists, antagonists control pituitary output during in vitro fertilization, and so on. So the corpus luteum now. So be careful, my beloveds. This is a temporary endocrine gland. Yeah, God is awesome. After ovulation, the ruptured follicle transforms into the corpus luteum and transient but powerful endocrine structure. If pregnancy doesn't occur, it functions vigorously. If pregnancy doesn't occur, it functions vigorously for about 10-40 days before undergoing programmed cell death, so-called luteolysis. The corpus luteum primarily secretes progesterone, essential for preparing the endometrium for potential implantation, making it secretory, increasing vascularity and glandular development. It also produces estrogen and inhibin A, contributing to the negative feedback on this HPO, hypothalamic pituitary ovarian axis, during the luteal phase, if its lifespan is genetically programmed unless rescued by human chorionic gonadotropin produced by an implanting embryo. Why it's so important? So luteal, for example, luteal phase defect, inadequate progesterone production, or a shortened luteal phase less than 10 days can impair endometrial receptivity, potentially contributing to infertility or early pregnancy loss. Diagnosing and treating this, for example, with progesterone supplementation, is crucial for fertility workups. Then, understanding early pregnancy. The corpus luteum is vital for maintaining pregnancy until the placenta takes over progesterone production. This happens around 7-9 weeks gestation. Ectopic pregnancy can also produce HCG, sustaining the corpus luteum initially. Menstrual symptoms. The withdrawal of progesterone following lipolysis triggers menstrual bleeding. Okay, now about endometrial regeneration. Monthly wound healing without scarring, normally, of course. The endometrium undergoes remarkable cyclical shedding and regeneration. So around 400 times in reproductive lifetime, involving extensive tissue breakdown, bleeding, inflammation, and subsequent rapid proliferation and differentiation, typically healing without any scarring. Normally, I repeat. So, menstruation involves, my beloveds, shedding the stratum functionalis layer, stratum functionalis layer. This controlled inflammatory process is followed by rapid reepithelialization, often starting even before bleeding stops. Very interesting. Driven by estrogen from developing follicles. The underlying stratum basalis contains stem progenitor cells crucial for this regeneration. The mechanism preventing fibrosis and complex and involves specific immune cell populations and growth factor signaling. What is clinical importance of that? If we take, for example, abnormal uterine bleeding, so dysfunctional regeneration or shedding processes contribute to bleeding. For example, heavy menstrual bleeding. Understanding the molecular control helps target therapies, for example, hormonal treatments affecting endometrial growth, antifibrinolytics like a tranexamic acid, sorry for my pronunciation, tranexamic acid, I suppose it's correct. Then endometriosis and adenomyosis, by the grace of God, we'll talk about these problems. So this endometriosis and adenomyosis, these involve ectopic endometrial tissue. Understanding normal and endometrial behavior provides insights into the pathophysiology of these conditions. Asherman syndrome, so scarring, intrauterine adhesions can occur typically after trauma or curettage, iatrogenic, disrupting the normal regenerative process and leading to infertility or amenorrhea. This highlights the usual resilience of the endometrium. Okay? So about cycle lengths. Normal cycle lengths variability is wider than often thought. So while the average cycle is of course 28 days, classic, studies show significant variation. Cycles ranging from 21 to 35 days are generally considered within the normal range. For adults, it's okay. Furthermore, individual variability from cycle to cycle is also common. So most variability occurs in the follicular phase lengths, time from menses onset to ovulation, as follicle development time can differ. The luteal phase ovulation to menses is relatively doesn't change, relatively constant, typically 12-14 days. due to the fixed lifespan of the corpus luteum without HCG release. Why it's so important? Many individuals worry unnecessarily about cycles slightly shorter or longer than 20 days, 28 days. No, individuals may talk ladies, of course. Educating them on the normal range is important. Defining irregularity. So understanding this baseline variability helps identify truly irregular cycles warranting investigation. For example, cycles consistently less than 21 days or consistently longer than 35 days, or variation up to 9 days, cycle to cycle in adults, potentially indicating anovulation or underlying pathology like polycystic ovarian syndrome. Or why not thyroid dysfunction? Fertility awareness emphasizes that ovulation doesn't always occur on day 14, critical for counseling on fertility awareness-based methods. So anovulatory cycles can still cause bleeding. Yes, not all uterine bleeding indicates a normal ovulatory menstrual cycle. Anovulatory cycles where ovulation doesn't occur can result in irregular bleeding patterns, often termed breakthrough bleeding. In an ovulatory cycle, my beloveds, follicles may develop partially producing estrogen, but ovulation fails. No LH surge, no corpus luteum formation. Without progesterone stabilizing effect and subsequent withdrawal, the estrogen primed endometrium proliferates but eventually becomes unstable or outgrows its blood supply, leading to irregular, often unpredictable, and sometimes heavy shedding. Estrogen breakthrough bleeding or estrogen withdrawal bleeding if estrogen levels fluctuate. A key step in so why it's so important? A key step in evaluating abnormal uterine bleeding is determining if cycles are ovulatory or anovulatory. Anovulatory bleeding is common at the extremes of reproductive age, perimenarche, perimenopause, and in conditions like polycystic ovarian syndrome, thyroid disorders, or hyperprolactinemia. Infertility. Chronic anovulation is a major cause of infertility, identifying it via history hormone testing, ultrasound, direct treatment towards ovulation induction. Endometrial cancer risk. Chronic anovulation leads to prolonged unopposed estrogen exposure, estrogen without progesterone opposition, which is a significant risk factor for endometrial hyperplasia and carcinoma. The menstrual cycle has systemic effect beyond reproduction. We know that. So fluctuating levels of estrogen and progesterone influences numerous systems outside the reproductive tract, including the brain, cardiovascular system, immune system, gut, skin, metabolism, actually all spectrum of metabolic syndrome. Actually, estrogen receptors and progesterone receptors are found in diverse tissues. Estrogen has neuroprotective, we know that. Estrogen has neuroprotective effects, influences neurotransmitters, serotonin, dopamine, so affects vasodilation, modulates immune cell function, influence gut motility, yes, and impacts skin hydration and collagen production. Progesterone has calming effects on the brain via its metabolite allopregnanolone. Sorry for wrong pronunciation. Via its metabolite, it's a metabolite, allopregnanolone acting on GABA-A receptor, raises basal body temperature and can affect smooth muscle relaxation. Why it's so important? So we have to understand these famous cyclical symptoms. Explain common perimenstrual symptoms like mood change, premenstrual syndrome, headaches, bloating, changes in bowel habits, acne flares, and fluctuations in chronic conditions. Differential diagnosis, Clinicians must consider the menstrual cycle when evaluating cyclical symptoms in any organ system. Treatment considerations. Treatment for non-reproductive conditions might need adjustment based on the menstrual cycle phase, or hormonal therapies might be considered for severe cyclical symptoms. For example, selective serotonin reuptake inhibitors. Actually, highly controversial this point, but just you have to explain all this to the patient. Then, next question about basal body temperature, BBT shift. So it's a progesterone thermometer, a very good thermometer. Progesterone has a thermogenic effect, causing a slight but detectable rise, so around 0.5 Celsius. No, in Fahrenheit it's around 0.5, 1.0 Fahrenheit. In Celsius it's 0.3 up to 0.6 Celsius. In basal body temperature. So progesterone has a thermogenic effect in basal body temperature after ovulation, which persists throughout the luteal phase. Progesterone acts on the thermoregulatory center in the hypothalamus. The basal body temperature shift occurs 1-2 days after the LH surge, confirming that ovulation has likely taken place. The temperature remains elevated due to sustained progesterone from the corpus luteum and drops just before or with the onset of menstruation if pregnancy does not occur. If pregnancy occurs, basal body temperature remains elevated. Why so important? Retrospectively, of course, confirming ovulation. Retrospectively. While not predictive, charting basal body temperature can help confirm if ovulation occurred in a given cycle. Useful in a basic infertility investigations or for fertility awareness methods, identifying the post-ovulatory infertile phase. Identifying luteal phase lengths, tracking the duration of the temperature elevation helps assess the luteal phase lengths. And low-tech monitoring, although less precise than normal assays, of course, or ultrasound, it's an expensive, non-invasive, and easy-peasy non-invasive tool patient can use. Now, mademoiselle, about menarche. Menarche timing and long-term health implications. So the age of menarche, first menstrual period, is not just a developmental milestone, but is associated with risks for various health conditions far later in life. Both early, less than 10 years old, and late, after 16, menarche can be indicators. So menarche timing is influenced by genetics, nutrition, body mass index, socioeconomic factors, and environmental exposures. Early menarche is often linked to higher cumulative lifetime estrogen exposure and factors associated with faster childhood growth, like higher body mass index. Late menarche reflect underlying HPO, this axis, issues or lower adolescent estrogen levels. Why it's so important? So for risk stratification, early menarche is associated with increased risk of breast cancer, endometrial cancer, obesity, type 2 diabetes, and cardiovascular diseases later in life. Of course, it's all menstrual metabolic syndrome chains. Changing lifestyle can corrigate everything. So late menarche may be linked to a higher risk of osteoporosis due to lower peak bone mass acquisition, but lifestyle modifications manage everything. By the grace of God, of course. Identifying underlying conditions. Significantly early or late menarche warrants an investigation for underlying endocrine disorders. For example, precocious puberty, delayed puberty causes like Turner syndrome, Kallmann syndrome, or hypothalamic pituitary issues. Actually, about public health, tracking population trends in menarche age provides insights into the nutritional status and environmental influences. Now, don't be astonished, don't be surprised. Immune system modulation, yes, I find this question. No, actually not in our institute, university, but anyway. So immune system modulations throughout the cycle, actually very good question, very good. So the immune system function within the reproductive tract and systematically fluctuates cyclically, influenced primarily by estrogen and progesterone, creating a balance between pathogen defense and tolerance for potential implantation. So it fluctuates cyclically. Estrogen generally enhanced pro-inflammatory responses at lower concentrations, but can be anti-inflammatory at higher pregnancy levels. No, TH1, TH17, yeah. Progesterone is predominantly immunomodulatory and anti-inflammatory, promoting TH2-based response and tolerance, crucial for preventing maternal rejection on the semi-allogenic fetus. These changes affect immune cell populations. So T cells, Tregs, NK cells, natural killer, macrophages, and cytokines profiles cyclically. Why it's so important, my beloveds? Autoimmune disease flares, conditions like multiple sclerosis, rheumatoid arthritis, systemic lupus erythematosus can exhibit cyclical changes in symptom severity, potentially linked to these hormonal immunal interactions. So understanding this can inform patient management and reassure them. So infectious disease susceptibility. Some evidence suggests potential cyclical variations in susceptibility to or severity of certain infections. For example, viral infections, candidiasis. Then, implantation success or failure. The precise immune milieu at the maternal-fetal interface is critical for implantation. This regulation is implicated in recurrent implantation failure and pregnancy loss. Very good question. About the cycle's influence on chronic disease management. Unfortunately, not in our questionnaire. Hormonal fluctuations can significantly impact the presentation and management of several non-reproductive chronic diseases, a phenomenon known as a catamenial exacerbation. For example, migraine. So this goes beyond genetical system effect to specific disease interactions. For example, failing estrogen levels premenstrually are a common trigger for catamenial migraines. Changes in hormone levels can affect neuronal excitability, implicating in so-called catamenial epilepsy, airway inflammation, catamenial asthma, and glucose metabolism. So be careful when you make your history with patient. So it's so-called personalized medicine. So recognizing catamenial patterns is crucial for effective management. Treatment strategies might indicate cycle-specific adjustments. For example, short-term preventative migraine medication premenstrually, just for prevention, or hormonal therapies aimed at suppress cyclical fluctuations. For example, continuous hormonal contraceptives, GnRH agonists. Diagnosis. Asking patients about cyclical patterns, I repeat it, that's not about only cyclical patterns. We have to be, me also, very very careful about this history pattern. So asking about cyclical patterns in their chronic disease symptoms, it's an important part of the medical histories, maybe crucial. Paramount importance. So actually patient education in it, informing patients about potential links between their cycle and the chronic condition can empower them to track symptoms and participate more effectively in their care. So all these 11 questions about the previous questions that confuse you, not all questions were and will be in your, thanks God maybe, thanks God always, will be in your questionnaire in exam tickets, but anyway, you have to know these points. Thanks for your attention. Don't forget to follow and subscribe my Dr. Y YouTube channel, and Don't forget to subscribe my Telegram Dr. Y channel, Dr. WHY. Dr. Y is me. Like question, no, without question mark. Huh? So you tap in searching mode, Dr. WHY, you find this, you click start, and you choose your plan. Choose the cheapest one. And you will find a lot of questions like this, MCQ tests, questions, answers, explanations, PDF format, video format, interesting clinical cases, students cheat sheets, why not? And something like this. Stay blessed.